So I think we are now, thank you, Mario, live streaming. Mario, if you have joined us on holiday, thank you very much for your dedication as usual. Mario is our technical god who helps us. So welcome everybody to September Health in Hackney. I've had apologies for absence, or lateness really, from Councillor Patrick, who will be joining us remotely in due course. Just in terms of matters of housekeeping, this is obviously a hybrid meeting with people in the chamber, people online. I won't do a round of introductions now, but I'll introduce the people for each item. We are being recorded, we are being live streamed. Members of the press sometimes watch either recorded or live. Please, if you're in the chamber or online, please use your microphone, which is, if you're in the chamber, bottom right button when you're speaking, but when you're not, turn it off, and that's the same for online as well. Please, if it's your item, please keep your camera on. Members from external organisations or the council, if you finish your item, you're then more than welcome to go. We appreciate you're very busy and have other commitments. And please don't start conversations in the chat. I haven't been notified of any declarations of interest. Are there any? Looking around, no. Then let's start. The main first substantive item we have on the agenda is in relation to the increasing mental health needs in the borough. And I think part of the reason that this came about to be on the agenda at this time was in relation to the increased weight of some patients at the Homerton. There was also the announcement by the Met that they were going to stop responding to certain calls, and then we had conversations about also just understanding what the service could look like going forward with the future plan. And so hence we're very grateful for the presentation that's being provided. We're joined by our Borough Director, Jed Francique. Thank you and welcome. We're joined by the Clinical Director of City and Hackney, ELFT, Dr. Andlauer, who's also in the chamber, welcome. And also Sharon Evans, who's the pathway lead, the crisis pathway lead, welcome for City and Hackney. I presume you're probably based out of the Homerton, where I sort of last visited your predecessors there, and we've also got members of the council, public health, and Healthwatch as well that may wish to contribute. So, Jed, your presentation is in the pack and starts off at page 11. Do you wish to start off?
Yes, thanks. What I was proposing to do, if that's okay, is just use some of the slides to highlight some of the key points, probably taking no more than about 10 minutes between us, and then leave space for discussion and questions, if that's okay.
That's perfect. Could you just a pet thing of mine, if you just give which page you're looking at when you're going through the slides, just so everyone to make sure they're with you, would be very helpful. Thank you.
Yeah, will do. So I'm going to start off with, I think this is page, must be page 12. Looking at, thank you. I'll probably use that. I'll probably use the paper copy rather than.
That's fine. All the members have got it, so I can see page 12 there. Scope of the presentation.
Yeah. So I suppose the first thing that I wanted to highlight was that obviously mental health is everybody's business. Obviously at ELF, we play a key significant role, but we wanted to emphasize that we only play an important but a specific role, and it's in terms of responding to the needs of local communities who have got mental health difficulties. It's important that we in ELF work really closely with LBH colleagues, with voluntary community sector colleagues, with primary care, police, etc. So I just wanted to emphasize that point at the beginning. In terms of the presentation, it very clearly focuses on one slice of the cake, the ELF kind of picture, and focusing on our responsibilities. And again, in response to the original query, what we primarily are looking at is people who present in crisis, mental health crisis, and kind of how we respond with partners to those needs, but also we give a bit of an insight into the community services that we provide, because that's also an important part of the picture. So Dr. Anna was going to talk about some of the context on the next slide.
Yes, so if you look at the following page, which is 13 in the pack, it's just some data that have been gathered as an exercise we did within the ICS, the Integrated Care System in North East London, supported by colleagues, to look at the offer we have and perspective and planning, strategy developing. And we thought it'd be interesting to put this slide as it highlights the level of needs in city in Hackney in terms of mental health. So you can see the way to look at it rather than looking at number is the gradients from green till red, green being the most favorable depending on the metric, and red being the highest level of challenge, if you want. So if you look at purely in terms of mental health, you can see that it in Hackney is present quite a high level of challenge, high level of needs, mental health, depression, long-term mental health problems reported. Similarly, looking at population well-being, so broader mental health other than mental illness, you can see as well that City in Hackney is among the borough that presents as the highest level of anxiety reported by population, for example. We know that mental health is very, very tightly linked with levels of deprivation. There are many, many, many factors that influence mental health, but levels of deprivation is one. And again, looking at levels of deprivation, I'm sure in this assembly, people are very aware of the challenges the population in Hackney is facing and continues to face, such as indicators of deprivation. Again, comparing with colleagues in North East London, there are certainly some very, very important challenges. And finally, physical health is it's a bit more of a mixed picture with some very, very encouraging and positive aspects, such as life expectancy at birth remains a challenge, as well as 65, but physically active adults is very, very good news. And finally, substance misuse. There's a lot of comorbidities between substance misuse and the influence it can have on mental health. And you can see again that it in Hackney figures among the highest, by far the highest, in terms of presentation for alcohol-related conditions or admission for mental disorder due to alcohol. So all of that to put in context that basically City in Hackney, as we know, presents a set of challenges in terms of the acuity and the severity and morbidity related to mental health, as well as some of its determinants.
So just before Sharon goes through the way in which people in crisis get into the system, a couple of just things to quickly add to what Olivier just said. One is that since the pandemic, there's an estimated 20 to 25% increase across the country, globally even, in relation to increasing mental health needs. So there's this ongoing increase, which obviously the capacity and resources in mental health system haven't been able to keep on top of. The other thing is probably worthwhile emphasising, particularly in the context of City in Hackney, is mental health difficulties are not spread equally. So there's certain parts of the population where there will be disproportionately hit hard by mental health difficulties. And that includes people in relation to things like ethnicity, age, sexuality, sex, people with learning disabilities, neurodiversity, long-term health conditions. So those are examples. And also, just re-emphasising the point that Olivier made, there's a really strong relationship in relation to deprivation and mental health difficulties. So again, in the context of deprivation in Hackney, that is one considerable issue. And what research has found, that if you live in the most deprived areas, you're twice as likely to need mental health support than if you live in the least deprived areas. So obviously those things are really germane to City in Hackney. So Karen's now just going to go through the system and how we get into the system and respond.
Hi, so I'm just going to give you a whistle-stop tour of our crisis services. If you go on the next page after what Olivier was presenting, there are 3 ways in which to access our services in crisis. There'll be psychiatry liaison, that's via the Homerton University Hospital Emergency Department. We also see people that are on the inpatients unit, acute inpatients unit. The other way is the crisis line. It's a 24/7 number. Anyone can phone at any time. If they're in crisis, crisis is self-defined. So they will phone up and we will triage and then decide what's the best way to support the service user. Another much more informal way of accessing our services is the crisis cafe. This has got set times. We find that a lot of people come into crisis or feel a bit more isolated out of hours, starting from about 5 o'clock. So we try and capture that demography using the crisis cafe. It's very informal. People can come in at any point, share with a group, or they can ask for a one-to-one. And if the clinicians within that service or the therapists within that service think actually this is a bit more acute, they can then link in with the other two areas, which is A&E or the crisis line to support. Now, what we do, for example, in HPM, psychiatry liaison, they will assess, people get triaged by the emergency department, they will be referred to us. We will assess the risk and need, and then we will find what is the most appropriate avenue to support the service user. So there's a range of options that are available to us, which is inpatient admissions or back to GP, it could be health-based or safety, or referral to acute support in the community, home treatment team, or it could be more support in our community teams, the neighborhood teams, for example, primary care. We work very closely with our voluntary service agencies as well. So some people will get support via that way, and we do refer on to these services. Crisis line also have an urgent assessment team. They will do a triage much in the same way and then find which is the most suitable option for service users. So if you go on to the next page, just look.
Just before you do, can you just explain what's the difference between the home treatment team and the community mental health team? How do they differ?
So home treatment team in essence is alternative to hospital admission. So it's very acute, sort of like support, where you'll either get visits twice a day or once a day, depending on the need. And it's quite intensive, but it's very short term. So anything from 2 weeks to a month, just to get people out of crisis, and then refer on to community mental health teams that do the longer term support and more therapy-based activity, whatever they feel is necessary for the service user. So A&E, as has been mentioned by both Olivia and Jed, the numbers have been going up. The acuity has been much more complex. We're seeing a lot more people that we've not seen either in community services or anywhere across East London Foundation Trust Mental Health Services. So new presentations that are coming to us quite unwell as well, where we find that we're using the Mental Health Act a bit more. The usual suspects of what people are unwell with, suicidality, social stressors, you get self-harm, depression, you also get psychosis, bipolar, but overall, that's what we're getting in the emergency department. The performance for our psychiatry liaison service, actually one of the better ones across the Northeast London footprints. I think there's about 6 emergency departments that are covered within the Northeast London. But the data that it shows that actually Homerton psychiatry liaisons performing quite well. Our response time's quite good. I mean, 81%, we'd like it to be a bit higher. But there is a lot of customers coming through the door, so we are working as fast as we can to support people. Some of the issues are quite complex. It could be things like housing, substance misuse, so it takes a little bit longer to support service users in that regard. There's also the recent issue that's been coming up a bit more about bed pressures and access to more beds within mental health services, which is recognized, I think, across the country, that this has become an issue. There's some of the data there will show how we are performing against our other teams within East London. That'll be Tower Hamlets, Royal London Hospital, and Newham General Hospital.
And just a clarification question on the first graph on page 15, top left, the attendances. So that's saying that's the City and Hackney number vis-a-vis the average East London number.
That's correct.
That's right. And then essentially, although on the next slide about the 12-hour breaches, although that's coded in terms of City and Hackney, in reality we're talking about the hospitals, we're talking about the Homerton, we're talking about presumably Barts with Tower Hamlets. Yes, that's correct.
So, I mean, we thought about just moving on to the beds because we don't want to spend too much time on slides because you have them in the back. So, looking at the slide entitled Local Mental Health Bed Stock and Occupancy, which is a fundamental part of the system. You can see that female acute beds 38, male acute beds 50, male psychiatric intensive care unit beds 15, mother and baby unit beds 12. So we have got beds in the local system. One of the things that's probably fair to say is that, again, there's a strong view, especially nationally, that there aren't enough mental health beds to respond to the needs in the population. So that's one generic issue. Even though our length of stay has been reducing, it is still longer than I think we'd hope it to be. And I think in terms of use of beds, there's increasing pressure related to the acuity that both Olivier and Sharon have spoken about in terms of people needing beds. And what the graph in the middle at the bottom shows is the use of private beds and B&Bs. So to supplement the actual beds we've got in Homerton, in our local system, we've had to use private beds when there's a need for an admission, but we haven't got a local bed available. So that's been a challenge. Also, where there are people that are starting to get better, and we're testing out, for example, whether or not they are able to move back into the community. We sometimes put them on Section 17 leave, relocate them to a B&B with support around them to again test to see whether or not they're ready to go back into the community. But the point is that our bed capacity is outstripped by the need. So we are actually supplementing our bed capacity by use of private and B&B. And obviously private beds are very, very expensive. So that's again part of the picture in terms of what's happening.
And just for clarification, as we're going through, what we're seeing there is the total number of your beds. That is presumably, tell me if I'm wrong, for those that the emergency admissions. That's not, for example, dealing with when we go to West Ham, look at the older age people with mental health under the units we visited. Charlie, what's the name of the unit we visited in? Was it West Ham where the services got? East Ham, yeah. Where they got transferred to. Yeah. So that's not. So it's just including the more emergency admissions at the state. There are other beds East London has.
Yeah, that's right. These are predominantly for City and Hackney people. I mean, that's kind of where this starts out, and it's working age adults. So older adults, as you say, are supported elsewhere. We do have situations where there's an incredible urgent situation, for example, in Homerton A&E, where we might need to admit somebody from either a different part of the ELFT system, or sometimes in exceptional circumstances where the responsibility resides elsewhere. But predominantly, these are beds, acute beds, and a PICU bed, male psychiatric intensive care support unit beds, which are targeted towards City and Hackney residents. That's the target for them. But as you said, there's older adult beds elsewhere, etc. So that's the picture in terms of beds. And the final thing on this bit really is just thinking about what we're trying to do in relation to improvement and transformation and development, because, you know, we're describing kind of the challenges, but we also want to talk about some of the things that we're doing. So I'm going to give some headlines in terms of what we're doing in the crisis and urgent care side of things.
So within the crisis pathway, for example, with the crisis line, I hadn't mentioned early on, but in the crisis line, we've been seeing quite a large number of people, a volume of people calling our crisis line, which doesn't really, what we're commissioned for, it outstrips what we're able to deliver, really. So some of the things that we've been thinking about as a system across East London Foundation Trust is maybe centralizing and pooling together staff so that there's a centralized crisis line that can support all the residents within East London Foundation Trust. That means we've got more staff that can sort of like be there to answer calls and readily available for all service users. The other thing we were looking at is the Rabel Center. I think our long-term plan is to have some kind of a crisis assessment hub within Homerton, where we can sort of like support more people who are in crisis in that area. It's a bit of a long-term plan, so we'll be looking at investment and thinking about how we can restructure what we have already to support the need. The other thing I think the other issue was about a retention of staff and getting more staff on board. I think a lot of crisis services suffer with high turnover for staff. And we started doing, I think, things that the staff have mentioned, things like training that they've been interested in. So we started introducing a training package for all staff that are working within the crisis pathway, hopefully to help retain some of the stuff that we're doing. We had a recruitment campaign that we've been doing for crisis pathway. So quite a few things that we're trying to work on and see whether we can get more staff on board and retain them, make sure they feel supported.
Yeah, and I guess just to build up on that specific point, because you mentioned it, Sharon, there's recruitment challenges, again, nationwide, locally in London, in East London in particular, where we are doing slightly better than the average in London in terms of vacancies, but there's recruitment, but also we've seen since COVID a big turnover of staff because people change life and move out of London and all sorts of things, and the living crisis and so on, meaning that we are slightly more successful at recruiting than other parts of London, but still having a whole lot of new staff require a lot of other senior staff to supervise them, and providing a lot of teaching opportunity, which I think we're quite good at, but that still takes, again, extra resource, extra time, and there's a lot of experience that's turned over in the last 3-4 years, and that's true in acute services, on the wards in the hospital, and in our community teams. Now, we've mentioned obviously the wait in A&E and people waiting in A&E for a bed. And that's obviously one of the main challenges we're facing. And there's part of what Sharon touched on is the trying to develop as much as possible an alternative to admission and an alternative to attendance to A&E. But next to that, as Jed was pointing out, our capacity in terms of beds, in memory at least, I've been working in East London for 10 years, has never been such an issue. By far, we've never had to use private beds to that scale in the past. And therefore, we have always been working, but have renewed our efforts on our inpatient unit so that the flow of patient can be as efficient, as optimal as possible, so that only people who absolutely need to be in hospital are in hospital. Which would usually work well with people. No one wants to be in hospital if they don't have to anyway. So alternative to hospital are always good to take. So trying to improve our as mentioned, obviously having as few vacancies as possible, having good staffing levels is very important to keep the flow going, and having people with experience, well trained, well supervised. Thinking about our response to changing patient profile. As we've mentioned, the complexity has gone high, the acuity has gone high, whilst all services have slightly tightened their criteria, be it us, the community sector, the vulnerable sector, social care, meaning that the acuity has gone up. So trying to respond to that with developing different activities on the ward, thinking with the occupational therapies, what can be done so that the profile that we see on the wards we meet better the needs. At the same time, we've seen also an increase in the complexity in comorbidities with physical health issues, sometimes very, very significant physical healthcare issues. So we've massively widened offer that, recruiting nurses who are physical health nurses working on our unit, training people, reactivating our GP service on the wards, a whole set of offer again on the ward so that we can respond, for example, to those new needs. Making sure our process and governance are up to scratch, and making sure we got a good oversight of the patient flow and where the need is. We are commissioning, Jed mentioned B&Bs, so that people can be, who don't have a place that's ready for them to go because a deep clean's waiting or something else, then we use B&Bs, but we're commissioning our own step-down beds so that, again, people who are getting ready for discharge can have a place to go that's safe, that's well looked after, where we'd have, again, staff around them so that they don't have to be in hospital. And all of that, as was mentioning as well, we have lots of initiative around improving staff well-being and experience in training so that people feel supported, choose to work for us and stay with us.
So we thought we'd pause there before going to the community to give the opportunity for questions around the crisis, emergency, urgent care side of things, if that's okay.
That's helpful to break it up. So I had Councillor Adebayo first, then Councillor Turbo-Delov. So Councillor Adebayo, who's online? Grace, you're on mute.
Oh, thank you. Just want to find out if there is any waiting list, and from the feedback in July 2023, you know, there is a long long waiting list. Is that waiting list or waiting time in the hospital?
Sorry, just to clarify, you're referring to waiting list or waiting time in which setting?
The crisis line.
Oh, the crisis line. Okay, sorry.
Yes.
So, yeah, so in relation to crisis line, one of the challenges that Sharon's spoken about is that the number of people call in, I mean, I think there's 2,000, something like 2,000 calls a month, but the number of people call in far outstrips the capacity we've got. So one of the challenges we've got is people are waiting longer than we'd want them to wait. So that is definitely a challenge. And also there's an issue in terms of abandoned calls as well, because when people are waiting long, they sometimes give up and might phone back. So there is an issue around people waiting for long periods of time to get through on a crisis line. That is definitely an issue. And that also leads to abandoned calls. But again, this is part of the conversation in terms of trying to get the right level of resources for that crisis line so that actually people are responding to in a timely way. But it is a challenge at the moment, definitely.
Councillor Tubdalov.
Thank you, Chair. Thank you very much. I want to just check a bit further on the data you provided to us around service improvement and transformation you mentioned. I looked at it with interest, especially the bit where you say that you will explore more information on frequent attenders and uptake. My question is related to data gathering, and I'm just wondering if your team collects already data on presenting issues of these frequent attenders, in terms of more particularly related to where these presenting issues are related to social issues happening at the moment, like, you know, because we are in this horrendous cost of living crisis, and how much of, say, unemployment, social housing or housing crisis are affecting and these recurring or peaks that we're seeing. My interest is that I think there is not enough link or how social injustices really are having this peak on mental health. And it would be really good that if we don't have that data yet, not gathering that, will your team consider doing that? Because it will really inform a lot of the local authority. Thank you.
Yeah, there's the first part of the question was specifically on frequent attenders and data. So what that maybe Sharon can address, because there's a team specifically dedicated to working with frequent attenders.
So as for part of Psychiatry Liaison, we've got we call it High Intensity User Service team, HIUS. So they specifically is there to support people that are using, I think there's a criteria for it, how many times people are calling 999, how many times people are coming through the emergency department. There's another one, I think 111 as well. So using those facilities to come through the department. And that team is there to then support people. We do gather the data, how many times people are coming in, who's coming in, and then they then go deeper. Well, what are the issues? What do we need to be looking at? How can we support you? And then they come up with care plans, so individual care plans for people that are frequently coming through the emergency department with either mental health or physical health or both. And if there's anything that we can do, for example, some therapies, link them into the right services to put in place. And actually that team, the lead one of the senior nurses is doing a QI project to really look at what's going on, why are people continuously presenting, even though there's these services in the community, what's bringing them in, and how can we turn this around to reduce the amount of times people are coming into the emergency department, make sure that they feel really supported in the community. And she's currently working on that right now, actually. It's quite interesting, some of the data that she's come up with already.
So just one point, just adding to what both my colleagues have said, just going back to the point of social stresses. So again, one of the things we know definitely is that there are a range of social stresses which you've alluded to that are contributing to people going to mental health crises. Definitely, we know that. So that is something we're trying to understand, and that's part of the reason. Again, going back to the beginning, in terms of response to mental health needs, we understand it's not just a kind of a medical ELF thing. It's got to be something where a range of different partners who understand financial well-being, housing, etc., are part of the picture, and that's how we're trying to respond to the issues.
Is it presumably then the fact that you, just on that housing point you made at the end, that you're having to put people in B&Bs, presumably because they do not have presumably if they had a home of their own to go to, you could provide a community service in that home. So, I mean, presumably that's indicative. The B&B rise that we see in that graph on page 20 is indicative of possibly homelessness being an issue. Is that something?
It's, I think it's an understatement to say that it's a very significant issue and contributes to the challenges we have in terms of length of stay on our wards. For people in B&B, we try to use B&B only if there is a reasonable, credible plan after the B&B. Otherwise, they would just be putting people in B&B for an indefinite periods of time. So that could be, as I was mentioning, for example, someone who we know already and they're ready today, but their flat is not ready, but we know it's coming. As that can be a provider that's hasn't completely finished to put furniture in, or we don't have the keys yet for whatever reason, but the person is ready today, and so they could spend 3, 4, 5 days a week in a B&B waiting for the last bits to be sorted. More generally, we're working very, very closely with the housing service, or bed meeting. There's someone from housing attending every week so that we can get updates for people who don't have anywhere to go, are homeless, sofa surfing. One issue as well around housing is people who have no recourse to public funds, where obviously then it becomes much more complicated to find ways out of hospital and somewhere to go. So we have a no recourse to public funds specific worker working in our team who really has had some great success unlocking some really intractable situation, liaising with Home Office to clarify the situation. So yes. Are
you allowed to put those people in a B&B because of the no recourse? Are you allowed to do that or not?
We would try. We can.
Yeah.
But if we don't have a plan after 4, 5, 6 days, then we come back to the drawing board. It is not supposed to be a long-term solution. It's a plaster, and that's that significant cost as well. So putting someone in a B&B without any prospect of what's going to happen after,
yes,
would put in a quite difficult situation.
It feeds into your point, because if you put people in B&Bs that you want a outcome to, but if they don't have an outcome because they can't qualify for housing, which does fall into the recourse of public service issue, that then you're in a vicious cycle sort of situation.
Absolutely. Yeah.
And can I just ask, just in terms of us and in terms of working with us as a local authority, and whether there's more, obviously, you know, we see it all the time as councillors in terms of incredible pressure on housing, and you know, and many of these committees can make recommendations to the housing team because there's so many pulls. But just to understand, I mean, I'm not asking you to be critical, I'm just asking in terms of constructive, is there more work that could be done to help you in that liaison with the housing team at the council, to try and sort of, you know, because presumably if you know that you've got an outcome in 3 or 4 weeks where something could be available, that then enables you to more confidently place. I mean, is there further room or recommendations or thoughts about how that could work better with the council?
I think the positive thing is that we're having positive conversations with LBH colleagues about how we continue to move it forward. So in terms of recommendations, it's about continuing to work together and deepening and strengthening the relationship that we have, to work in that multi-agency way to meet the needs that we're talking about. So I think we are having positive conversations with LBH colleagues, and it is about continuing that direction of travel and strengthening kind of the approach that's been taken. I think there's a fundamental issue though, obviously in terms of housing, and I think there is something about us collaboratively probably thinking about mental health and housing, you know, almost like a workshop, taking a big step back and thinking, are there any fundamentally different solutions that we need to explore, to pilot, to trial? But the relationship with LBH and the conversations are positive. I think there is something about how we kind of continue to think about different solutions as well.
Yeah, I mean, I can see other people wanting to come in just on that. So it just set me thinking that I mean, are you starting to collect in a way the data of the cost of you on private beds and B&Bs to make a spending case, to be crude about it, too, for the system to say, actually, the system would be better if LBH were able to develop a certain housing offer, then the overall system could be cheaper in a 5-10 year plan, as it were.
Yeah, that's exactly what we're working on. So we've been doing exactly what you said, which is gathering data on how much we're spending on B&Bs and on private beds to see, well, actually, if we had this money available to us, what alternative might be more appropriate. So that is part of what we're doing, yes.
Thank you. So I saw Sally first, then Councillor Adams, then back to Councillor Adebayo. So Sally from Healthwatch. Sally.
Thank you, Chair. This may be a conversation to take offline, but I'm just thinking there's an opportunity here. As you know, Healthwatch Hackney are coming in to do the entering views in the acute mental health wards planned between, I think next week's the first one, running into January. And normally when we do an entering view, we're asking questions about kind of the service there and then. We've been talking about, this is an opportunity to ask about people's wider journey coming in. What could have stopped you getting to this point? What was your experience if you're if you've gone around in a circle and come back again, what could have stopped that? And I'm thinking it might be worth having a chat with you. Is there anything else we can explore? For instance, questions around housing. Is there anything we're missing to make sure, because we've never done this before, it's a unique opportunity and we really want to make the most of it. So I think it would be nice if we could link up ahead of that and have a chat.
No, that'd be really, really helpful.
Brilliant. Yeah. Thank you.
Councillor Adams.
Thank you for the presentation. You said that steps have been taken to centralize the crisis line across 3 boroughs. Is this due to staff shortages, and how much knowledge we call handlers have of local provisioning and etc.?
So the centralization of the crisis lines, it's a combination of things. I wouldn't want to say that it's just about the staffing, but that it helps if we're able to pull our resources together. There's another direction that NHS England want us to take with 111 calls. I don't know whether you've heard about 111 press 2. So eventually what NHS England would like is, like, instead of phoning a local number, you just dial 9111 press 2 and you go to whatever the local crisis line provision is in that service for mental health, a bit like what you do for 111 for medical concerns. So that's another driver that's been sort of like us, that's led us to start thinking about centralizing it. We've also now started to merge with, I say merge, we're working much more closely with Northeast London Foundation Trust, because of our ICD is all aligned with each other. So some of that is trying to streamline the services so they make sense. There's not too many strands going off. At least we're more organized in how we are approaching the support for our service users. So it's a combination of things, but I would say staffing is one of those issues as well that we've had. The long waits are not unique for crisis lines. They're not unique to City and Hackney. Same problems as being experienced in Tower Hamlets and Newham. So, but if we combine those staff together and they focus on, supporting people on the crisis line, we are hoping would reduce the wait time for service users on the crisis line. Oh, and sorry, I've also just to say, we were talking about the centralization of the crisis line is different in terms of when you need an urgent assessment, a face-to-face, that's going to be retained locally. So if you phone the centralized crisis line, they will answer and they think actually you need an emergency assessment, they'll come back to Hackney. Our urgent assessment team will then be able to see the people locally so that people don't have to travel out of area to get those assessments. So we're really trying to streamline our workforce and make sure that it's working for us the way that's quite sustainable, really.
And correct, Councillor Adebayo?
Thank you. Just a quick one. Is there any possibility of us getting the data on the first-time users, those who access the service for the first time and those who have the relapse?
In short, yes. I don't have them at hand here. What we know is also the proportion of people who come through the door in crisis that we don't know, that are not known to our teams, is quite high. It's a significant proportion. And It depends how you want to see it. You could think that it's a good thing that people who would have a team would contact that team, who would be known to the service, would seek help early from that service rather than going to A&E. So I mean, their needs might be met in the community, but on the other end, obviously we would want to meet with people before they reach crisis point and attend A&E or call the crisis line, obviously. And so it's about early detection and working closely with primary care and the transformation. Maybe we'll have a few minutes to talk about our community service offer, because prevention is always better than the cure.
I mean, can I just make an observation on the? I mean, I've, you know, significant. I mean, it just to draw an analogy to the GP services in Hackney, going back 5 or 6 years, we used to have a Rolls-Royce service that was funded very well, whereby the out-of-hours GP was the line was staffed by GPs. So if you called through, you immediately got through to a clinician. I think that was widely felt to be one of the factors why the Homerton had such a good A&E system. Of course, then comes the government or NHS diktat that you've got to pool into 111, where only about 12% of people get to speak to a clinician. Everything else is done through the automated and a more advisory role reading out from a computer script. So I mean, you know, it's you know, you're less speaking to a fully trained clinician. I mean, you know, I mean, I'd be resisting that at all cost. I mean, I can see the benefit of of elevating mental health as being on that 999 111 level as a port of call, but to lose I appreciate it doesn't have to be borough based, and merging the crisis line across East London, good, fine. So I can see how that provides better working. Or if it's all go national, I just see that as a race. From what we've seen through 111 nationally, I personally see that as part of the problem with A&E attendances, because, you know, people are just not getting any useful. You're just going to hit an algorithm on the 111. So I don't know, but I mean, I'm just sort of encouraging you, if you can, I mean, from what I've seen, to push back as much as you can on any of that. I mean, that would strike. I don't know what your views were, and you could probably be a bit more diplomatic, whether you would agree with that sentiment or not.
What I can say is, first, from a pragmatic point of view, the offer, the clinician who will answer the phone will remain ELF clinician, our clinician, trained in the same way, and our senior clinician who will have been trained. And we've developed, I think, a really, really impressive offer in the last couple of years on training, or with, you know, people can join in the senior day very regularly in supervision, listen to the calls to make sure the quality is there, etc., etc. But we are very keen to keep a local offer indeed, rather than having a massive system that gets completely depersonalized, doesn't know the local population, doesn't know the local needs, the local communities, the local services, etc., etc. Absolutely.
So just to understand, I know we're going to move on to community in a minute, just to understand where we are with what was concerning a few months ago in terms of the number of the 12, I think, breaching the 12-hour timescale at the Homerton. Has that plateaued or steadied of late, and is that partly because you're having to resort more quickly to private beds and B&Bs as a way of easing the flow? I mean, what's just the update of where we are, as whether that 12-year breach is getting better or not?
Yeah, I mean, it generally, I mean, the average is 4% of people coming through the door of Homerton taking longer than 12 hours to basically be seen and move out of A&E. I mean, as of last week, because we look at the figures every week, so as of last week, for example, there were 5 out of about 90 attendees at Homerton that breached 5 hours. And the longest one was something like 15 hours wait. But it would be fair to say that there are some very specific cases where it is longer, and quite often, as I think has been alluded to, it's quite complex situations, sometimes involving other responsible trusts where there's difficulty in working out kind of who's responsible, but also the bed situation contributes. But the numbers are relatively low. It really is kind of 4%-ish generally.
Just the other thing, what was the update on where we got with lease, have they relaxed their hard deadline on not accepting calls? So where have the briefings, where have the conversations got with that?
Yeah, my understanding, I don't know if Georgina Diba is on the call, but certainly my understanding is that they've not gone through with the hard stop at the end of August. And I mean, what they're working towards, as I understand it, is still working with partners to come up with a much more reasonable kind of, excuse my language, soft landing in terms of how the system works to accommodate and respond to the needs of people with mental health difficulties and kind of supplant the police role. But so they haven't pursued the hard stop that they were talking about previously.
Thank you. Okay, well, shall we go on to the community aspect now? And then I think we've got maybe sort of 15 more minutes with you before I go on to the other items on the agenda. So maybe 5 or so minutes on the community. And also I think we're particularly interested about the long-term plan and how you possibly see a redesign going through.
Yeah, so the slide, nationally driven community mental transformation, that slide which is talking about the long-term plan ambitions. So this has been around for about 4 years, and all parts of the country, including here in ELFT and City and Hackney, we've been working towards this new model which integrates in primary care and community care. Is, excuse my language, but a biopsychosocial model. So it's not just about, it is thinking about social aspects, psychological aspects, and the medical aspects. It's a broader model, particularly focuses on, amongst other things, access to psychological therapies, but also, again, thinking about some of the conversations we had previously, the so-called wider determinants of health. So thinking about things like housing, amongst other things. Also, there's a very clear focus on health inequalities. So it's a much more, it's very ambitious. There's a lot of money put towards it. And we've been organising ourselves in response to the goals and aspirations of the model. So amongst other things, the neighbourhood teams is a response to this, trying to have multi-agency meetings where we discuss referrals, etc. All of those things are part of the response. In terms of where we want to get to, though, which is the next slide, is we're in the process of trying to kind of pause and reflect on where we've got to in terms of the transformation. And sorry, the thing to emphasize with the transformation is it's not ELFT. This is not an ELFT mental health transformation. It's a system transformation that necessarily involves local authorities, voluntary community sector, housing, etc. So it's a real system transformation that's aspired towards. So one of the things we're doing is trying to kind of pause and reflect in terms of how far have we actually got in terms of achieving the goals and aspirations of the model. So the model, the workforce development, the system working, the goals in terms of outcomes and data that's aspired towards in terms of understanding the needs. So doing an exercise in ELFT. First stage is looking at doing an exercise in ELFT. Next stage is going to be doing with system partners to understand where we've got to and to co-agree what the next steps ought to be. So we're thinking, okay, this is where we've got, but actually in terms of priorities, in terms of the next phases of developing the community offer, we want to make sure it's co-agreed with system partners. We also want to agree a system vehicle for overseeing the next phases of that development as well. So we know that, so it will include things like a review of care pathways. It will include things like, when it says cultural safety training, what that's about is making sure that staff feel confident and competent in terms of responding to diversity, cultural diversity and diversity of need of people in City and Hackney. So they feel confident and competent to kind of respond to that need. Workplace wellbeing, which we've talked about already. And also thinking about delivery points, just the final kind of point I wanted to make really, delivery points, which is actually how can we make sure we're delivering care closer to home? So actually there's points within the community where people can receive services, go and receive services in a kind of a local venue, ideally working with system partners as well. So that gives a flavour of it. But the fundamental thing is, going back to the crisis side of things, is, excuse my analogy, but the crisis is kind of the part of the system that is burning very brightly, let's say. And what Olivia's alluded to, what Sharon's talked about is, we need to get upstream of all of this. This is part of the solution, and make sure we've got a robust community offer that supports people in the community. And that's got to be a system offer where ELF is working collaboratively with LBH partners, voluntary community sector, primary care, etc.
And I would No, go ahead. No, I would say there's obviously ELFT was a pilot. There were 12 pilot sites in the country to be early implementers of the transformation alongside neighborhoods. And so there's been already, our service have been reconfigured to align with the neighborhoods, but also to change the way they're working. So we've developed notably, I guess an illustration of those early steps towards that is that we have created a lot of new roles, quite innovative. We've used the R system to have senior members of staff who work across ELFT and GB practices. So they can really be the link between primary care and our teams. We consider GPs and members of staff in GP surgeries as part of what we call our blended team. So anyone from primary care can drop in our daily meetings. If there's a referral that's a bit complicated, it's quicker to give a quick account rather than writing referral forms and sending the notes from the consultation. The GPs are very welcome to attend those meetings as well as our regular meetings. And that's the same for all our system partners. With a Turning Point that comes very regularly and other partners. Another example is of those new roles that kind of like embody a little bit those new ways of working are community connectors. We've always worked very closely with Beavan and Derman, the local providers of the voluntary sector for our communities. Now we're employing them through the voluntary sector. We have community connectors whose role is to connect people with the community and the offer in the community, both statutory and non-statutory. And there are members of staff from Derman, from Beavan, from Mind Area who are working now through them for us in our team to have this sense of connection alongside IPS. We were mentioning employment. That's a big, it works really well. Employment support in the team. As people supporting people, whether they are, and no matter how significant their difficulties with mental health could be, working with people to get into competitive employment. And that can go from writing your CV, how do you dress up, preparing for interview, where are your skills, what do you need to work on to get the job you want.
And so just taking that forward, I mean, obviously I think the councils at last year recommissioned the Mind network with Booker and Derman. But taking it forward, are you then at the stage where, for example, when the council's at the stage of recommissioning that, you're sitting around the table with them, with the Homerton Eye Act, and saying, maybe with whoever's in charge of social prescribing across the borough, how can the system work best together? I mean, are you at the table in designing that? And similarly, are they sitting down, helping, discussing with you on the community, presumably more the community side of your commissioning and how it works? I mean, you're presumably you're going to that stage, but I mean, that's the logical conclusion about where you're getting. But is it happening at the moment to that extent?
Yeah, I mean, the key vehicle for discussing mental health issues is via the Mental Health Integration Committee, which ELF, LBH, Voluntary Community Sector Partners, and others sit on, ICB partners. So there is a vehicle that kind of holds the rig on mental health agenda, which, for example, Wellbeing Network, which is commissioned by LBH, the Psychological Therapies and Wellbeing Alliance, which is led by ELFT, all feed into it. So I think there is a vehicle for having those joined up conversations. Because I'm a dreamer, I would always say there's always more that can be done to continue that integration and joined up working, collaborative working. There's always more that we can do, and I think we've been talking about kind of how we continue to strengthen that.
I was a bit confused, is probably too strong a word, but I didn't fully understand, I still don't, with the recommissioning of the Mind network. What was stated as the sort of one of the objectives is to provide more high levels support, as it were, but I didn't get the impression anything was necessarily taking away from the other levels. I was sort of a bit confused as to how that was in reality being achieved. So how is that, from your perspective, that mental health network supporting at the higher end?
It's a good question. I think one, I'm not trying to duck it, but one, there's a system, a global issue, not global, a local issue in relation to there is more need than we've got the capacity to respond to. So there's always going to be gaps. So that's a fundamental issue. I think there is an issue about how collectively we keep our eyes on mild to moderate mental health needs. I think there is an issue about that we need to kind of give further consideration to, and how we join up what's happened, what the different parts of the system, what the wellbeing network does, what's the psychological therapies and wellbeing alliance do, including what the Tavistock do, what ELF do, etc. So I think that there's been commissioning that makes sense in the context of kind of the circumstances we're in, but there's always more we can do because we do have gaps, and there's always opportunities to join things up, I'd say. But mild to moderate is an area that I think is of concern.
Back to David Mayer's time when he was sort of at City in Hackney, he was pushing that about stage. I've got two questions. I see Councillor Adam and Councillor Tobit Delov, and I see Helen there.
Thank you. I just want some clarification on pursuit of 5-step down beds. What does that mean?
So essentially, for people that are in our acute beds at the moment in Homerton Hospital that are getting better, that might need kind of what's called a step down before they go back fully into the community. So there's 5 flats that we're commissioning that will have some support wrapped around it. So people can come off the ward into one of the flats with some support to see how they adjust to living back in the community. So it's kind of, excuse my language, it's a softer landing than going straight back into your own home. So that's what these step down beds are. It's a step down before you get back fully into the community. So we're commissioning 5 one-bedroom flats. That's what we're trying to do with wraparound support.
Thank you, Chair. This is a question about, related to what you alluded to within your transformation for mental health. I really liked how you referred to transformation as system, which seems very much clear. My question is, might a little bit maybe perhaps be bordering a lack of more detailed knowledge on where funding is and how it's allocated across mental health services in the borough. I'd like to hear your thoughts on how currently the national and local model on talking psychological therapies have a number of referrals, but has quite a big dropout rate on completed treatment, and how that model is inspiring or informing the initiatives that you talk about for more community based on what you have listed here as the sources for transformation. So I'd like to hear where you are at with the model now and how does that inform the future, hopefully, transformation. Thank you.
Yeah, I would say there's a very wide, diverse offer in terms of talking therapy, to speak very broadly, in City in Hackney, but it's true that it's provided by a lot of different providers, primary care being by the Homerton with soap changes. There's off-center for young people. Some part of the primary care psychotherapy is also delivered by Baker Hollymore Derman as well for the specific communities. Then we have the Tavistock, who's providing a very specific service, mainly for GP surgeries, for frequent attenders in the GP surgeries, as well as far as I'm aware, that obviously we're not providing that service, it's Tavi, as well as medically unexplained syndromes. And then there's the offer in ELFT, and that would be in the neighborhood teams. We have groups that have been developed for specific issues such as anxiety or emotional dysregulation, for specific groups that were identified as needing that offer supported in primary care. There's then within our recovery service, so that's people who have longer term needs, who needs care coordination and more regular input. There is a psychology offer as well, with psychologists working in those teams. And there is a specialist psychotherapy service, which provides more specific psychotherapy. There's a wide range, cognitive, analytical, mentalization-based, advanced CBT for complex needs, etc., etc. So there's also an offer there in terms of talking therapy, and that would be, I guess, the most specialized therapy, if you want. Now, there's been an increase in demand everywhere. Within our services in ELF, the specialist psychotherapy service, there's been a really, really important piece of work done in liaison with the new offer, I guess, in primary care, so that the quality of the referrals and number of referrals be more appropriate. Because referring someone for potentially a year or two of therapy, that you need to be ready to engage with that. And therefore, having that upstream offer in the neighborhood and in the other teams helps then screening more tightly the referral to the specialist psychotherapy service, so that the people who are ready to access this service can access it, because there's still a wait of a few months to access those complex therapies. And therefore, putting people on a waiting list who are not ready is a waste of time for everyone. Obviously, for the service user first, and then that might even reinforce the idea that anyway it's not going to work, or nothing's going to work if you don't manage to hold on with the commitment and with the intensity of the therapy, as well as obviously for services and other people who could access those therapies, having other offers for those people. That's how things are structured, very in a nutshell, really whistle-stop tour.
And can I just say a crude just addition to what Olivier said? I mean, there is something that we are trying to do, which is continuing to try to understand just the point you're making about dropout, the fit of the service offer with the needs of the client. And that is something we're trying to understand, because obviously part of what that might mean is services should always continue to evolve to make sure we're meeting the needs that are presenting. So that is an ongoing piece of work. So in Psychological Therapies and Wellbeing Alliance, for example, there are conversations about kind of who the clients are, kind of what their experiences are, kind of and what the outcomes are. So that's part of the work we're trying to do. But definitely there is something about kind of the world's changing, people's needs are continuing to evolve. We need to make sure that our service offer continues to evolve with their needs.
And it may be, I think we had a review actually with IAPT a number of years ago now, but it may be an apposite time just to bring the specific IAPT service back, just to ask about that dropout situation.
Chair, we did raise it for the Northeast London part of possible topics for discussion, and it's on the agenda, so maybe they,
no. Because or we there's a Homerton item who specifically commissioned the IAP, we can sort of ask them. Helen, I was probably quite cheeky to ask ELF colleagues about your service, so I'll let you come in.
No, at all, Chair. I actually just wanted to add a little bit around the commissioning. I thought it was an interesting discussion around commissioning. So just to add for context, we have agreed with our health partners that we will have a joint mental health commissioning role. So we've started the development on that, and then we're looking at a wider integrated commissioning unit that will follow on from having the joint mental health commissioning role.
That's very useful to hear. Yeah, and I think just following on from what Jed was saying, I mean, that mild to moderate sort of, the extent to which more focus can possibly be given there, because I think that's something with this committee's heard year in, year out, and possibly being a gap, but I appreciate it's a difficult one with funding. Thank you, everybody. I've gone slightly over, but I think we haven't got a completely packed agenda compared to sometimes. So I'm going to draw this to a close now and say thank you very much to our colleagues from East London Power Station Trust. I mean, that was incredibly helpful, both as a sort of an overview of where we're at, but also just a good discussion about where it could be going. So thank you all very much indeed. That's much appreciated. I'm going to move on to the next agenda items. So as I said at the start, I understand you've obviously got busy roles to go on to tomorrow, so please feel free to leave us at this stage. I'm going to move on to the next item on the agenda, which is the City and Hackney Safeguarding annual report. This is offered by nature. Annual report comes before us every year. We're grateful for, I think there was some delay with the printing, and we had a summary in our agenda pack, but we've now been provided with the full document. As usual, we're joined by Dr. Cooper, who's independent chair of the board, Georgina Diba, the Director of Adult Social Care and Operations, and Shoaib Ahmed, the Safeguarding Adult Board's manager. Dr. Cooper, shall I, can I ask you to start off and then maybe open it up?
Thank you, Chair. Can you hear me all right? Just checking.
We can, yes.
Well, so thank you for that introduction, and apologies again for the late submission. It was due to some design delays, and I'm hoping that people have had a chance to have a look at the annual report. So I've been chairing the Safeguarding Adult Board for Sitting Hackney since 2015, and so there are ongoing challenges and new challenges that we've been facing in terms of safeguarding adults in Hackney. What you've got in the annual report, as always, is both a combination of what the board has achieved, but also reports from our partners around the work that they've done during the year to safeguard adults in Hackney. Your cover paper included the various achievements that we've been able to report over last year. So our statutory duties around safeguarding adult reviews, we published 2 and commissioned 1, and there is an ongoing improvement agenda arising from safeguarding adult reviews, which identify where there are areas for improvement in the way people practice and in the way agencies work together around that. We did quite a bit of work last year around communication and engagement, training and awareness raising, and continued to do some joint work, for example, around antisocial behaviour and transitional safeguarding. The report summarises the work that we've done. The report also contains the priorities that we developed in a workshop earlier on in the year for this year. So you've got an idea of what we're looking at focusing on during this year, which continues to really, I suppose, really very similar things, although interestingly in the light of the earlier conversation, there have been some issues that have emerged, like the Metropolitan Police's attitude to working with people with mental illness, and how that's been raised through the board as well as through other networks. So we've reported on that. There's also been some ongoing work looking at the impact of the cost of living crisis and trying to understand how that might have impacted on safeguarding adults during this year. So some of these things were already happening last year, but continue to happen into this year. And you've got the priorities that we're focusing on during this year as we move forward. I think I didn't want to go into too much detail. The data is not particularly significantly different to the data for previous years. At one point in the year, there appeared to be a real increase in the amount of self-neglect that was emerging. We looked at this at the board and through the quality assurance subgroup. And so I think that what you get is a summary of the board's work, not the kind of detail and nuances. And certainly other colleagues, Helena and Councillor Kennedy, are here who attend the board meetings, can show that can testify that we do look at some of this in detail during the year as we meet 4 times a year. I'm happy to answer any questions or comments that members of the committee might have regarding the detail, but I didn't want to go into it too much at this stage by way of introduction, Chair. I hope that's adequate to introduce the report.
That's very helpful. I can go straight to questions. Did anyone else, did Georgina or Cheryl have anything to add at this stage, or shall we just go straight to questions?
So Cheryl has given his apologies because of childcare. I don't know if Georgina's here, if she wanted to comment on anything.
I am, but I'm happy to go straight to questions. Thank you.
Yeah, thank you. I mean, just one observation, just on the number of concerns that were raised vis-a-vis the number of 42 inquiries. Appreciate the point that it said that it's largely in line with the previous 2 years. Just an observation, just in terms of transparency, it perhaps would be helpful to give those figures, because I don't think we can't find the figure anywhere in the report, but it's just an observation just to provide. It's just a transparency point, really. Question for me, just in terms of where are we up to with the new liberty protection safeguards replacing DOLS, and any challenges you've experienced in that process?
So I'll answer the second question first. So the Department of Health and Social Care has put that on hold. the proposals, the consultation, the feedback, the result, it's been deferred and deferred and deferred, and now they've literally just put it on hold. Having said that, there are still ongoing challenges, I think, for maintaining good assessment of mental capacity in the context of safeguarding risks. So the fact that the DOLS and LPS work, excuse the acronyms, have been put on hold doesn't mean this isn't an area of focus for partners, because what we know from safeguarding adult reviews is this continues to be a challenge, and certainly in Hackney we've seen this in terms of supporting people in managing risk in their lives. So I don't want to give the impression that this isn't, as you know, just because the government has put this on hold means that we've stopped thinking about this particular area of work. But actually, in terms of the changes to the system, that's literally stalled. Just going back to the earlier question about the comparative work on concerns and inquiries and the data, as due to the problems that Hackney Council has had following the cyber attack, we have had issues with getting comparative data. What we've tried to do through the board is get as much data as we can, which is why you have separate data from the Sunderland Foundation Trust, and use that to create a picture. But it does mean giving year-on-year comparisons for Hackney in particular has been problematic. I think the data only takes you so far anyway, and there's only so much you can conclude. It's really the data gives you a prompt to ask questions rather than tell you in detail what's going on. But I think Georgina may want to respond on this.
So I think, I mean, the data is really important and is something that we use, I think, really to inform the actions we take and the areas we want to focus on. I was just trying to look up quickly the data from previous years, and I will share that with everyone on Health in Hackney afterwards. I think for me, the data, again, it's about driving those actions that we want to take, particularly as kind of you'll note in the report, we talk about self-neglect and hoarding being more reported within Hackney comparatively to other areas. And hence, you know, there might be different actions we're taking as a result of that.
Thank you. And then just in terms of the issues that have been with the reporting, presumably now, next year, I appreciate in the previous years there might still be that historical issue, but next year you'll be back to be able to present the data.
Yeah.
So from previous years, I think I've seen breakdowns of what the different concerns raised and what categories they fall into.
Yeah, absolutely. I think year on year we will see more robust data from across both the local authority and ELFT systems, because it's a collective view of safeguarding. I think the other important thing to remember is that while we might look at data and we use data, we also do a lot of qualitative analysis. So looking at case studies, doing case audits, trying to understand people's experience. And I think, you know, we have to take the numbers, but also, you know, seek to understand from people how that journey through safeguarding, did it make them feel safer? So there's lots of different ways that we look at data and using the system to understand how that felt for the person.
Thank you, Georgina. Councillor Adams?
Yes, thank you, Chair. Thank you for the presentation. I'm just looking at page 28, key achievements. 8, the board undertook a self-assessment using the Safeguarding Adult Partnership Assessment tool, which was assessed by an independent reviewer during the Partnership Development Day in March 2022. I was just wondering if you could share the outcome with us of that review. Is that possible?
So it was a really helpful exercise. The tool that we use is used by chairs and boards across London. So it's something that's fairly widely used. Partners are asked to fill it in, and we asked an independent person to do a review and assess that. And she was able to come up with a number of areas and questions that then were discussed in the first face-to-face meeting we had since COVID. We had a workshop where we looked at the issues that she raised. And it's the output from that that has informed the strategic priorities for the year forward. So it was a really helpful piece of work. There were also quite a large number of new people participating because of turnover during the last 2 or 3 years who hadn't met each other. So it was a very quite exciting and productive event on lots of grounds. I think it would be fair to say that we have, I mean, there is quite a detailed analysis. We have made a decision not to put all of that detail and analysis into the annual report, to keep it quite sort of short and brief. But unless colleagues have any objection, we can share the information, if that's appropriate, with you, if you would like to see it after the meeting.
Please, yes, if you could, that would be helpful, colleagues. Can I just ask, in terms of the first priority about the mental capacity assessment, can you just talk us through, raise awareness? What does a mental capacity assessment look like, and who undertakes it, and how does it assist you?
So I think colleagues, Georgina is closer to the delivery of the services, and other colleagues who were here earlier in the Mental Health Trust are much closer to the practice around this. So what with mental capacity assessments, it has to be, it's under the Mental Capacity Act, and they are decision specific. A number of people can undertake mental capacity assessments, as long as, you know, we have the required training, knowledge and skills to do it. Why it's so critically important with safeguarding is that someone's ability to make a decision about risk in their lives is very much affected by their mental capacity to do that. And people may have fluctuating mental capacity, or their mental capacity may be affected not only by, say, for example, a learning disability or mental illness, but also if there's coercion or undue influence being exerted on them by other people. So it may also be affected by physical health conditions like diabetes, for example. So there's a number of very different ways. Substance misuse, alcohol use can affect somebody's mental capacity to make a decision that's going to affect their safety and safeguarding issues in their particular environment. What we find from safeguarding adult reviews is that there's a number of situations where the complexity of how those decisions are made is not fully understood, maybe by everybody involved in someone's support and care, which is why there is this ongoing drive to prioritize improving people's practice and understanding of this particular area of work. I'm not sure if that answers your question fully.
Yeah, I think it does. I think that helps. So basically, I think what's coming out of some of the SARs is learning is that possibly things may have, for example, could be picked up at an earlier stage through a more informed and nuanced reply to mental capacity assessments completed by partners. Is that
So I think where it comes down to is that often people make assumptions that somebody has the mental capacity to make a decision to keep themselves safe, and doesn't necessarily apply their professional curiosity or get information from other partners to be able to say, well, actually, maybe these decisions are not being made with full, and I'll differentiate slightly, something called executive mental capacity. So someone may be able to say, yes, of course I can do the right thing and keep myself safe, but actually their ability to actually do the things that make them safe in that situation, the executive, so the ability to execute the actions to make themselves safe or protect themselves from harm, is not necessarily fully understood. And it's a very nuanced and I think ongoing area of understanding and development that practitioners, you know, on an ongoing basis need support to understand and reflect on, because sometimes these are very complex decisions that somebody also has the right to maybe do things that you might think are not maybe in their best interests, or, you know, might be a bit dodgy, to use a technical term. But for, you know, we can't interfere with people's choices. You know, we have to allow support people to make choices to take risks in their lives, because lives are risky. So it's a balance around risk assessment and the mental capacity, and particularly the executive mental capacity, that someone can then keep themselves safe, or or make use of any particular things that may help them safe.
And you, that's very helpful, Dr. Cooper. And so your role in that is really to improve the training and people's awareness of how they complete that exercise.
So the SAF's role is to try, in a sense, the board, we hold each other to account. And my role as the independent chair is to say, well, how do we know that your staff are being supported to support the people they work with to keep themselves safe? So it also includes things like reflective supervision, discussion, case discussion, people having the support from their managers or their supervisors to talk through some of these often very difficult and complex situations where they're trying to help somebody who maybe doesn't want their help, for example, and is maybe taking risks that, on the borderline, or some days they can keep themselves safe, and on other days they can't. In a way, that it's the areas where it's fluctuating, which I think are most difficult. People may remember the Safeguarding Adult Review of Musa that was done, the man who was homeless in Stoke Newington, and there were a number of people who were involved. Actually, there was a lot of mental capacity assessment work going on. However, there was there was learning out of that around his refusal of help, for example, from the ambulance to take him into hospital, where perhaps in hindsight, someone might have said, well, we should have overruled his preference to stay in the bus stop and actually taken him to hospital, because he was putting himself at such acute risk. And I'm reminding people of that Safeguarding Adult Review, although it's a very stark and quite distressing, it was very distressing history. That's the complexity. Sometimes people are trying very hard to do the right thing, but it's complex and challenging for the practitioners as well as for the person who's experiencing difficulties.
That's very helpful in giving us an understanding of it. Thank you, Dr. Cooper. I think there's a gentleman here, sorry, I don't know your name, who's going to make an observation. So if you just introduce yourself and use the microphone.
Yes, I'm sorry. Thanks, Chair. My name is Joe Okedwe. I'm a senior lawyer for adult social care. I just wanted to add to what Dr. Adi has been trying to explain. I think it's more of understanding the two-stage tests under the Mental Capacity Act, which is basically the diagnostic test and the functional test. Sometimes individuals can pass the diagnostic test, but not the functional test. So it becomes quite difficult to actually make a conclusion that they lack capacity or that they don't lack capacity. So it's quite nuanced, like Dr. Adi said. Yeah.
That's helpful. Thank you. And Councillor Adams.
Thank you, Chair. I just back to the key achievement number 3 regarding the safeguarding courses. I was just, as a matter of fact, I was just wondering what are the criteria for people to attend those courses?
So in terms of access to training, what we try and do through the board is run at various levels and options, depending on where people are in terms of their knowledge and understanding and their interest in safeguarding. There is a site, we now have a new training system where there are sites where people can see what courses are on offer. These are courses put on by the partnership. So therefore, anyone who's involved in safeguarding in Hackney who has the relevant role as a member of staff, or and indeed some are for volunteers, like the basic safeguarding awareness training courses. So I mean, they are available to anyone for whom the content may be relevant. They're not restricted to one or other service.
Thank you. I'm just trying to look around. Any other members' questions, or I don't think there is, unless I've missed anyone. So thank you, Dr. Cooper, as always. And yes, that was very helpful in terms of just giving us those sort of practical examples in terms of the mental capacity assessment. So thank you very much, and for your continued good work on behalf of the borough. So thank you. So I'll draw that item to a close and then move on to the final substantive item of our agenda, which is the Healthwatch Hackney annual report. It's in our agenda pack. Welcome here to the Executive Director, Sally. Welcome, and also the new Chair, Deborah Cohen. We're glad to see, I think, now 2 permanent people in post, and it, you know, so we appreciate there's sort of been some change over the last year or so. But we're very much glad and welcome you both here. Congratulations on the award you won, the Impact Award, in terms of your work, in terms of GP practices, asking for identity. I think that's certainly for us, as I was sharing with colleagues before, that was certainly a standout piece of work that enabled change to happen in the local area. So we're grateful for that. I don't know which of you would wish to start off presenting the report, and then we'll open up for questions.
I think I'm going to start. Thanks very much for inviting us here. I think Sally's we're going to have a slideshow to go along with the reports that you've got here. There we go. So anyway, I just wanted to say that you know, I'm very pleased to be the new chair of Healthwatch Hackney, and it's been doing some fantastic. The staff have been doing some fantastic work in finding out what the people of Hackney think about the health services, and a whole variety. They do so much on so few of them, and they cover so many different issues. So anyway, you know, just a bit of background. My experience: I was a health journalist, health and science journalist for the BBC for a very long time. So I've never worked directly in the health and social care services, but I've reported on it. So I feel like I kind of know quite a lot from the outside on it. So so that was so again, we were going to say, you know, the most exciting thing to happen was the award, and it wasn't just any award. As Sally pointed out to me, it's the only award that Healthwatch England, our parent body, gives. So it's not just one of many, Oscars. It's the one to have. So congratulations to the team for that. And then we just wanted to go through some of the highlights of the year. You can see the number of people we get to, and all the different kinds of, you know, thanks very much to the volunteers who come along and go off to do interim views and comment collection. And we're going to talk a little bit more detail about some of the special reports we've done over the last year.
Thank you, Deborah. Just up on the screen here, as you can see, this is an example of the kind of the feedback that we get, which we look at this feedback, and it helps steer us to know where do we want to investigate, where do we want to focus our energies, where do we want to go and do outreach, where do we want to do interim views, what special reports do we need to do, and this is taken from the last financial year. So there's some encouraging stuff in here. It's really nice to see when you look at GPs that overall satisfaction has gone up by 18%. It's really nice when you look at Homerton that you can see again, not only has overall satisfaction gone up by 2%, but actually there's quite a big green chunk there. So we look carefully at this feedback, which comes from such a wide range of sources. It comes from outreach, it comes from work that we do going into services and talking to people. It comes from people phoning us up and sharing their experience. We also reach into things like Google reviews about dentists, about GPs, anything that we can get our hands on really to find out what people's experience. And that's where we base our evidence to focus our energy. I wanted to talk to you a little bit about the different projects and contracts that we hold. I think we're really unique as a Healthwatch. We hold our core Healthwatch function, which is the signposting, the interim views, and the work that all Healthwatchers across the country do. But we also hold contracts through the NHS, which enables us to not only perform that sort of watchdog function that all Healthwatchers do, but it enables us to do a lot more collaborative work with the local services and to really work together. So we've split them up across each of these slides. The work that we do with the neighbourhoods, with our neighbourhood resident involvement manager, I think is a really good example of the collaboration between Hackney CVS, Volunteer Centre Hackney, and ourselves. Hackney CVS provides the neighbourhood forums, and part of our role is to ensure that residents not only know that the forums are happening and come and have their voice heard, but there's a lot of work that goes on behind the scenes supporting those residents, training them and upskilling them so that when they come along to the forums, they're not just there feeling a little bit out of their depth and thinking, oh, I don't really know what to say. They're able to come along and really share and express. These are the things that matter to us in our very local patch, in our neighbourhoods. And we've been working through the neighbourhoods to do some work embedding co-production. And coming soon, we've been doing quite a lot of work on producing very localised kind of insight reports, capturing what is the feedback from each of those individual neighbourhoods to share with services. Another one of our NHS contracts is the Community Voice contract. That's very, very much about what it says on the tin, capturing the voice of local people. It's a very practical project. It's based on outreach. We host forums in which we invite the wider public to. We support different parts of the system with outreach in terms of surveys, lots of focus groups. Just a few examples of some of the work that contract's taken on lately. We supported a project around spirometry services, and we were delighted to have nearly 2,000 responses to a survey that we put out in the local area to try and find out what people thought about localising those services. Work on virtual wards, a very in-depth piece of work around living with long COVID, and that really explored not only the impact of long COVID on people's lives, but that was really looking at the fact that we know that there's a great long COVID service in Hackney, but we do know that it's only accessed by particularly white women over the age of 35 to 40 seem to be accessing that service. So we did a lot of work talking to our local communities and trying to understand what are the barriers for people really engaging with that service. And I'm delighted to say that actually linking in with the long COVID services, that report's been published fairly recently, but we're already seeing the recommendations for that service being implemented straight away to allow more people to access that service. So that's quite an exciting piece of work, we feel. And we also hold the engagement and co-production contract through the NHS. Now, this is a contract that's hosted by Healthwatch Hackney, but the role of our engagement and co-production manager is really a role for the whole system. And she works to support and embed co-production across the health and care services. And she supports a group of people called the public representatives. We're very proud of our group of public representatives. They range in age from our youngest is 19, our oldest is, I think, 92. And they're a very diverse group, lots of different life experiences, living with various different health conditions. And they work very closely with different parts of the health and care system to offer co-design, engagement, support and advice. And just some of the examples over the last year are work that we've done with the London Borough of Hackney Advocacy Services, and that was the procurement exercise that LBH undertook. We had public representatives working as an equal partner as part of that procurement exercise, which was fantastic. We've had public representatives involved in various things, including sitting on the interview panel for the Chief Participation and Place Officer for NHS North East London, and feeding into part of the governance system with the People in Place group. Also, I'll very briefly touch on, this is one of our projects we're very proud of, the System Influences is the project which allows young people to get involved with the system and influence the system. We are about to start our third iteration of this program, and it works pairing up young people with mentors from within the health and care system, and it really allows them to do quite a broad range of work, but it's engagement, it's looking at comms from a young person's point of view, and not only are they able to influence the system, but it's part of getting them upskilled, giving them skills and supporting them towards the workplace. Our last iteration, which took place in 22 to 23, out of our young system influencers, 2 of them moved directly from our programme, taking those skills and experience into paid work within the local health and care system. And that is something that we're building on with the next iteration to really bring more young people into the health and care system as workforce.
And just moving to the next section, apart from the interim views that Healthwatch has a statutory requirement to do, Healthwatch has also done these other specific reports, which are ones that kind of expose sort of poor behavior really, or things that really count and things where we can really make a difference. So there was one with the Chinese and Vietnamese communities to discover that actually the language barrier was still incredibly high in those communities for them getting the care they needed. There was a big project that also involved the whole of North East London to look at patient experience in maternity care, going back over about 3 years through the pandemic. And then the one that's really made quite a lot of impact was the one into the access to emergency hormonal contraception through the Hackney pharmacy services. And this was done with a kind of mystery shopper element, getting a lot of young people to go and see if they could get this emergency hormonal contraception and just without paying. And actually, we discovered that quite a lot of them were not providing this. So we're going back and doing follow-up work on this to see if this has changed, because it should have been available free. And then there's an accessibility audit of the community pharmacies. So it's great to be able to actually, discover what's not working well and hopefully manage to make a difference when we point it out to people. And then just one more quick thing that we do. Every fortnight, there's a people's feedback panel where we actually look at all the content that, all the comments people have made. Well, we don't get through all the comments because there's too many of them, but we go through some of them in an hour, see how many you can get through in an hour. People's comments on all kinds of things like care opinion, Google, to see what people actually write about. It's a rather different way of getting access to comments. About all kinds of things, from Specsavers in Dalston and Mare Street through to dentists. There's been a lot of comments about dentists and access to dentistry, through to GP surgery, getting appointments, and through to the Homerton, which is a different insight. So I think it's sort of fair to say that Healthwatch finds all ways of getting access to comments that people have got to make about local health services. And then there's the information exchange meetings, which are specific ones on particular areas that have been all held online. They haven't gone back to face yet, but they might do at some point. So that's basically what we've been up to, what they've been up to, not me, but what they've been up to.
Thank you very much for the comprehensive report. Can I just, how's it working with the ICB Partnership Board and the 8 different health watches from the different boroughs? Essentially, as I understand it, you've only got 1 rep on that board. So how does it work in practice with having Healthwatch having a voice through that system?
I think it's working very, very well. All 8 health watches meet fortnightly online, and we discuss everything that we're working on together. There's quite a lot of work that comes through the ICB, which affects all of us, so we're always able to work together. Hackney has had representatives going along to that ICB quite regularly, so I think it's working very well. And in fact, it feels very positive. But when there are issues that sit kind of with the ICB rather than locally, that the health watches are more and more able to come together and formulate a joint response. And I think that the maternity work in particular is a very, very good example of that, where each patch went away and did their own work around maternity. But when you put that all together, there was a very strong case to be made to now about where those changes needed to happen across the patch. So I think there's a lot of advantages in allowing those health watches to all come together and work together.
The areas that you're sort of thinking for the next year ahead are sort of priority areas. I hear you in terms of you take the feedback from the data and what have you, but that changes are afoot that you think need focus coming up in the next year.
Yes, I met very recently with Georgina, and we were talking about ensuring going into the beginning of next year that we would like to do a lot more work around social care and make sure that we're linking in more clearly with social care. So we're really looking forward to doing that work together. We continue to prioritise health inequalities, as that's the area that we will really be focusing in on across the next 2 to 3 years, making sure that we know you can't take broad brush strokes, and it's all about engaging with specific communities. And so I'll give you an example. We started off with quite a broad piece of work coming up in the near future. We started to think we'll be looking at what kind of health information, health literature there is out there for women. And then we started thinking, hang on a minute, that's far too broad. So we've narrowed it down. And so we are launching next month some really very close work looking at women's experience of menopause. We'll be starting by looking at like Black women's experience of menopause and how we can make sure there's appropriate messaging and literature and support out there for Black women in the local area. And then we'll moving on from there, we're starting to look at possibly work around menopause support for LGBTQ plus community. So we're thinking in terms of when we're addressing health inequalities, we need to focus in on very specific communities and do that work very, very closely with them to make sure that they're getting the support that they need. And that's a lot of our future work plan.
Georgina, can we ask you just to take the presentation down so we can see everyone on the screen? Councillor Turbidov.
Thank you, Chair. Congratulations on the award. Really well deserved. And I wanted to also add that I recently, I work very heavily with the Latin American community. Healthwatch in South London delivered a really, really fascinating workshop in Spanish, which is not often that our communities have this, and I'm looking forward to working with you to perhaps bring that to Hackney too. I wanted to check in your report, which I was lucky to have from before when I attended your summer session, under your power to interview, how do you decide which topics? I mean, there are so many, but how do you decide the topics, the areas that you will visit and review? And just as you were talking about the people's feedback panels, how do those feedback inform those decision-making process on topics? Just to understand how involved they get and how much you listen to those feedback. Thank you.
Very, very, very much the interim views, those particular area that are informed by the feedback that we're hearing. So when we hear concerning feedback, we think, okay, right, let's look at our work plan. Where can we fit in the right interim views for that? So for instance, we're doing the mental health interim views to the acute mental health wards. That's off the back of us receiving lots of feedback, particularly about that journey in, I think, through A&E and the long waits. That informed that. But for other examples, if at the people's feedback panel, quite a lot of that feedback might be around GP practices. And if we notice there's a particular GP practice where potentially it feels like there are red flags, we're hearing more issues being raised than at other GP practices, we would say, right, okay, we know that is the GP practice where we'll do the next enter and view. On people's feedback panel, it's just come to my mind to share with you, Canaria, our amazing enter and view manager who runs the people's feedback panel, extends an open invitation to, often to commissioning staff or providers, but I think she'll be very happy if I extend that invitation to you guys as well. It's every other Friday morning. There's such interesting sessions. You really go away with a picture of this is what people are saying on the ground about services. So if you would, any of you would be interested in coming along, you'd be very, very welcome to join that session and get an idea of how we kind of shape our work plan around those interviews based on those sessions.
Yeah, it's fortnightly, 10 to 11.
Other members for questions? One thing that's sort of, as you sort of speak, I mean, because you know you've been commissioned to do various projects, and then this a bit of what you're talking about promoting access of information with respect to the menopause. I mean, that balancing line between being the watchdog and the crystal eye, vis-a-vis being an arm of the NHS and being commissioned by it at times. I mean, how I mean, historically, you know, I think, you know, Healthwatch in the last 5-6 years have done very well to balance that line. But how do you, I mean, that must present constant challenges as to judgment calls on that. Can you just talk about how you navigate that?
Yeah, I don't believe there's a challenge. I believe that working collaboration is the way to achieve change. So I don't see it as an either or. A critical friend, if you like. We're able to recognise issues, we're able to share issues and work supportively with the system to resolve those issues. And I think Deborah and I are very, very clear, we don't see our role as a watchdog as in sitting to the side saying, that's wrong, we want to call you out on that, on you go and fix it, and we're just there watching for problems. We feel like we're there really to involve local people in the process, co-production, as much participation as we can. We want to be part of the solution as well as being that watchdog that helps to identify the issue. And I think we're both very, very clear that that is the way forwards into the future that we see for our Healthwatch.
And in terms of what you alluded to in terms of because obviously what we see a lot of your work being NHS focused, I'm very glad to hear in terms of thought being had to more on the adult social care side as well. I mean, how do you see that working? I mean, doing interim views, say, for community care provision, or I mean, what could that look like?
It's a combination. We've got obviously our interim views, so we would look at that for the work programme for next year. But it's also, I mean, Georgina and I have been having conversations about the work that we do around co-production, particularly with our engagement and co-production contract, and we run workshops, look at using the co-production charter as well. So using things like that to introduce our approach to co-production, and then supporting services to involve more residents in the work that we do. So for instance, the public representatives that we're very, very, very proud of, it would be a case of looking and suggesting, well, you might benefit from having public representatives that attend this meeting or do some co-production work alongside this programme, or system influencers, which is very, very important to us to make sure the young people get involved as well. So it's, yeah, partly that interim view, which is sort of more the watchdog side of coming in, looking at services and making recommendations for change, but also partly that thing of, are you involving residents? If not, we can support you to do that. We can help you to get on the right track with really getting a representative group of people coming to share their voice, share their views, and help you to shape the services. And I think that feels like a key part of what we'll be doing over the coming couple of years.
That's good to hear. And I think, you know, there's constant pressure on the adult social care and, you know, the constant churn of transformation agenda. So I can see how you could play a valuable part in assisting us and the wider community in understanding how that journey is going from a resident's perspective. I'm looking around. Are there any further questions? No, I don't believe there are. So thank you very much.
Thank you.
And obviously this is an annual item, and we're very grateful for the excellent work you do. And thank you very much. So with that, members, I will draw that item to close. The minutes are in the agenda. Can I have them agreed, please? Thank you. The work programme is at the back of the agenda. Jarlath and I have met and gone through and populated it with people's suggestions. I think I was going through it before. I think in some way or form we are seeking to encapsulate all the councillor suggestions in some way. Councillor Turbot-Delov, in terms of the Chagas disease, I think we're going to suggest that's done at INEL level, where there'll be a greater number to look at. So that's going to be our suggestion there. I'm just going through in terms of other areas. Councillor Patrick raised points in terms of outcomes for black men and maternity of black women, and I think there's possibly an item in January. We can look at that. Councillor Turbot-Delov, you asked about the charging regulations on migrants. Now that is something I think prior to you joining INEL we looked at quite extensively. So I think what our suggestion was is Jarlath will send you that sort of where we got to in terms of that that correspondence and that and those briefings. Councillor Samatar, we briefly touched. Dr. Cooper briefly touched upon hoarding. Councillor Patrick has raised about learning disabilities, and there's probably a conversation offline we want to have with her about how we can hone that down. Councillor Turbot-Delov, you raised about suicide and cost of living. Something we've touched at Scrutiny panel, and I think there's going to probably be a revisit of that in terms of when the year budget, because I think a certain amount of money was given for a year to support people on that journey. So I was possibly thinking that could be then revisited, and we invite you to Scrutiny panel to.
Thanks, Chair. I also think it would be good if we were to have those data that we're discussing tonight, because it will inform us as well on, say, levels of which we hear this is growing, how debt is, leading people to self-harm and suicide. So it'd be good if we were to continue to press for those or recommend them for them to happen, then that can inform us as well.
So sorry, to have the data already.
Data on what are the presenting issues for people self-harming, social, taking them into account, aside from what already is part of the assessment when people go and seek support, pay attention and focus also on social aspects such as debt, housing, homelessness. I don't know if these are part of the data that is gathered.
Yeah, I mean, I think we touched upon it briefly with ELFT. I think they said they were possibly with a certain cohort, the repeat client-based cohort, they indicated they were gathering that data. I mean, it's an interesting challenge as to whether other colleagues in the NHS whether that's gathered, and maybe a challenge we keep on making, but it's maybe something we can take away and think about as to.
I think, Chair, sorry, just if I may, it probably hasn't been a big focus on it in the past. I think people, I think practitioners are aware of it, but because of the cost of living crisis, I think we have a different level now of acute severity of it. So it would be good to kind of make sure that it happens.
Yes, indeed, and indeed linked to that, I think certainly one area we're going to revisit in the next year is sort of the outreach service, I think what was Thames Outreach, if it's sort of still commissioned by them in terms of who go and support increasingly people on the streets and the service they provide, which is linked in. And then there are other areas we've in principally about how just touched upon by Healthwatch, how neighbourhoods are interacting with PCNs, how that interacts with the Confed. I sort of see that as sort of like a critical area to understand for the borough. There are other areas obviously we need to look at with the new staffing structure, to be crude about it, if Hackney is losing out in a way because of sort of a uniformity across the wider patch and diktats from sort of NHS England about what the structure should look like at ICS level and what that means. So those are some of the numerous areas that we've got, but we've tried to encapsulate all the councillors' suggestions in some way or form.
Sorry, Chair, just very briefly, I'm sorry if I cannot see here, but there was a suggestion that I think may have come after the consultation on parasites being infections from parasites that might be carried through animal feces as well. I think it might be that actually might be for the commission, it might be for the public health team, I think you said.
Yeah, I mean, I think we're talking really specialist things.
I think what we'll do with something that's more specialist than that. I think if we ask public health and we find out sort of if there's a data set of a significant number of cases, and then if there is, we can then if it's a small number of cases, there's more of a bespoke response to you or whoever's asking it, and if it's a significant number, then we can bring it forward.
Okay, just maybe as a last comment on it, there is an increased number of residents bringing this topic up and this issue that there is continuous sort of animal feces not being collected, but because I've had my own personal experience of contracting a parasite from animal feces as a young person, that's cost me my partial blindness, is what I feel will be really good that this is sort of looked at.
Let's see if we can gather any. If it's possible to gather any evidence base on the public health or.
It's a member's question, public health, really.
Yeah, well, or we can. I don't see any harm in sort of understanding to try and learn the extent of the issue, and then that can inform how it's dealt with. Sally, I've got your hand up. Is that a legacy hand or?
No, I was just very quickly going to jump in. Just a thought that came to me as you were talking. Our public representatives were talking about kind of a social audit of our green spaces. It's something that they wondered if it might be useful looking at the forward plan, and I'm wondering if it possibly links in with what you're suggesting. If we ask our public representatives to go out, have a look at green spaces, if that's something they could report back on might just think with what you're saying, just keep in mind.
I think that's a good idea. I mean, we've got to be slightly careful to tread on toes of the other commissions who sort of linger, they sort of fall under. I'm always very conscious about working collaboratively with my chairs and not treading on other people's topics. But it may well be that I can suggest, say, living in Hackney, that Healthwatch reports back to them on that. Yeah, exactly. Yeah. Okay then. Well, thank you everybody. And with that, I will draw the meeting to a close and thank everyone for their contributions. Thank you.
Thank you.